Patient is a 67-year-old male who presented to other hospital with dyspnea on exertion, and he is found out to have an inferior MI, and he was thrombolized with retiplase, and later they have done a angiogram which showed a double vessel disease. Initially he had a moderate LV dysfunction, and after PTCA to RCA, his LV function has improved. He is a diabetic, and he came to our hospital for the left coronary stenting. So this is an angiogram that they have done, and you can see clearly the right coronary artery is there is total cutoff, and they have stented. When you see the left coronary artery, you can see there is a short left main. There is a nearly 80% stenosis of the LAD, ostial LAD, and there is a moderate 60 to 70% stenosis of the ramus, and not much of a lesion in the LCX. So this is an anatomicogram which was showing a short LMCA, which was showing a 70 to 80% lesion in the ostial LAD, and there is a small, there is a ramus which is showing a 70% lesion, and LCX not much. So at that time our strategy was to do a provisional stenting from LMCA to LAD. So this was the, we have decided to take the help of Ivus, and Ivus from LMC, from LAD to LMC was showing tight lesion, fibrocalcific lesion in the ostial LAD, and from ramus to LMC also is showing a tight lesion in the ostial ramus, and from LCX to LMCA, the lesion is there not much of a lesion. It is a fairly good ostium. So we have taken Ivus measurements. So ostial LCX was showing luminal area of 5.9 and 7.94, a bit distal. So we thought of leaving the LCX, and ostial LAD was showing it was a 3 mm vessel, and the luminal area was 1.6, plaque burden of 78%, and ostial ramus it is also some 3 mm vessel with a small area of 1.61 minimal area, so plaque burden of 61. So at this stage our strategy was to do a mini crush from LMCA to LAD and to ramus. Mini crush because it was a short LMCA, and there wasn't any guide support to the JL. So these are the other images which we wanted to take before planning our PCI. With LMCA, you can see the luminal area of the LMCA is 3.5 to 4.4. So we wanted to do a pot with 4 mm balloon, and for ramus, EM to EM was to 2.97 to 3.2. So we decided upon taking a stent size of 2.75. Ostial LAD, there was EM to EM is from 3.8 to 4.2. We wanted to take a stent size of 3.5. So for this is a fibrocalcific lesion in the ostial LAD. So with EM to EM of 3.75 to 4.1, we want to take a angiosculpt of 3.5. So we have pre-dilated the ramus with 2.75 into 12, and with the NC balloon, and the LAD we have prepared with 3.5 mm angiosculpt. So we have stented the proximal LAD across the diagonal with the 2.75 into 18 mm stent, and from LMCA to LAD with 3.5 and 18 mm, and 2.5 to 18 mm in ramus. So we have deployed the stents, and we have done a pot with 4 into 8 as we thought before, and this was a final kissing. This was a Bailey kissing. We have done with 3.5 into 12 and 2.75 into 12, and this was a report we have done with 4 into 8, and these are the final measurements, Ivus measurements, where you can see the ostial ramus has improved from 2.8 to 5.8, and ostial LAD has improved from 2.3 to 8.26, and the point of confidence, you can see LMC has also improved. This is the final result. So what is the take-home message? As Ivus can define the ostial areas and plaque burden, a safe strategy for LMCA trifurcation can be planned. Sometimes it can convert a trifurcation into a bifurcation. It helps in deciding which vessel is which vessel to stent and decide the main vessel and the main branch and the main side branch. And Ivus helps in locating the LMCA ostium. Thank you.